Bismillah ar-Rahman ar-Rahim. In the coming few lectures, I will talk about measures of disease occurrence and measures of association between a given disease and a risk factor or risk factors. But I will start with a definition for evidence-based medicine. Evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. Evidence-based medicine integrates clinical experience and patient values with the best available research information. Evidence-based medicine is an approach to medical practice intended to optimize decision-making by emphasizing the use of evidence from well-designed and well-conducted research. I got this definition from the internet. So, evidence-based medicine consists of three circles. First, relevant scientific evidence, clinical judgment, and patients' values and preferences. The interaction between these three circles defines evidence-based medicine. Again, this is from the internet, this slide. This slide shows the steps for building evidence. And I have loaded this pyramid from the net. The first evidence comes from animal and laboratory studies. Of course, the evidence from animal and laboratory studies should be further evaluated to know whether it applies to humans or not. The second level comes from case report or case reports, clinical case series, narrative reviews, expert opinions, editorials. All these can be called uncontrolled studies. The third level pertains to observational controlled studies, specifically cohort studies and case control studies. I think these studies have been explained to you by my colleagues. The next level is the randomized controlled trials, clinical trials. These are the gold standard for research, for evidence, for scientific evidence. And again, these studies, the design of these studies will be explained for you by my colleagues. The next level is meta-analysis. By meta-analysis, we mean collating the evidence from previous studies. And at the end, we develop guidelines for practice that physicians should follow in treating their patients. Why to measure disease occurrence? There are many reasons. First, science begins with measurement. Things that we cannot measure, we cannot study. Identifying the size of the problem and the burden of disease, which is important for health planners. At this time of COVID-19, we understand how important to know the number of cases, where the cases come from, and what ages are affected with the disease. Identifying time trends of disease. These trends over time can point to certain etiological factors. Identifying geographic variations in disease occurrence. Again, we can ask why the disease occurrence increased, why the disease occurrence decreased over time, why certain areas have higher levels of a given disease than other areas. We can also study the etiology of disease. We cannot study the etiology of disease without having good measures for disease occurrence. Sources of morbidity data. There are many sources of morbidity data. I will discuss some of these sources. The first source is notifiable diseases, routinely reportable diseases. In each country in the world, there is a list of diseases that when a physician encounters should report them to the health authorities. In Jordan, the list is about 50 diseases. Any physician diagnose any of these diseases has to report them to the local health authorities, مديرية الصحة. Then these will send the reports to the central authorities in Amman. These diseases may change from one time to another because the list is updated, revised every time. They are revised periodically, so it is not something fixed over time. Also, the list of reportable diseases, routinely reportable diseases, differs from one country to another, and they are mandatory by law. Reporting of these diseases is mandatory by law. Despite that, the main problem is underreporting. There is a substantial degree of underreporting. In the United States, only a small proportion is reported, 15 to 25%. In Jordan, the proportion reported is likely to be more, maybe 40% or 50%. Despite the substantial underreporting, this source of data may be very useful if we assume constant rate of underreporting. So it is easy to know about trends of a given disease over time if we can assume that the rate of underreporting is constant. Sentinel reporting refers to a type of reporting that obtains data from selected health centers or from selected areas rather than from the whole country. We select these sites because of their good history of previous reporting. And we try to select these centers to represent as much as possible the country as a whole. The purpose is that we are more able, or we may be more able to motivate a small sector or a small number of centers than motivating the whole centers in the country. One of the strategies to improve reporting is to have feedback, is to communicate with those people who are reporting and sending them feedback information. The feedback information may contain information about the size of the problem, about the prevailing organism, the antibiotic sensitivity of the prevailing organisms, and this helps those who report to acknowledge or to understand that their reports are being used for beneficial effect. This feedback is expected to encourage them to report more fully. Another source of data is the hospital. The data obtained from hospitals are characterized by their accuracy, but they suffer from two major problems. The first problem is bias by severity. Only severe cases usually reach the hospital, the tip of the iceberg. So patients who are hospitalized or who reach the hospital are not representative of all cases of that disease. The other problem is that the catchment area of the hospital is usually ill-defined. We don't know the population served by the hospital. We don't know the population that gave rise to the patients admitted to the hospital or who reached the hospital. Another source of data is the health centers and the private clinics, the disease registers or disease registries, such as the cancer registry or TB registry in Jordan. Special surveys are also the source of data on diseases. These surveys may be carried by the government or may be carried by universities or by research teams or even by individual researchers. There are many of these surveys being carried in Jordan. It is not time to discuss any specific surveys. Laboratories also can provide data on certain diseases, accurate data in fact, about certain diseases, but not about all diseases, because many diseases are not identified in the laboratories. Diseases that needs laboratory, such as TB, typhoid, malaria, and similar diseases are confirmed in the laboratory and therefore can be identified from the laboratories. But we cannot have information about upper respiratory tract infections from the laboratories because simply patients with these diseases don't go to the laboratories. Health insurance, employment exams, school health programs are other sources of data on diseases, but unfortunately they are not fully used. Now we come to measures of disease occurrence. We have two measures of disease occurrence. The first measure is incidence. The second measure is prevalence. Incidence has two forms: cumulative incidence and incidence density. Prevalence includes point prevalence and period prevalence. I will discuss each of these measures in detail. Before proceeding to obtain measures of morbidity, it's important to develop a case definition. This is usually based on a clinical, laboratory, or radiological criteria, but it is not always straightforward. The time of onset of disease may also be difficult to obtain. Diseases such as breast cancer, colon cancer, hypertension, diabetes may have occurred several years before diagnosis, but we often use the date of diagnosis simply because we don't know the time of onset. This is an example of a case definition for measles. Clinical case definition: an illness characterized by all of the following: a generalized rash lasting more than 3 days, a temperature more than 101 Fahrenheit, cough, coryza, or conjunctivitis. Laboratory criteria for diagnosis: positive serological test for measles, positive IgM, significant rise in measles antibody level by any standard serological test, or isolation of the measles virus from a patient. Cases of measles may be classified according to the degree of certainty in our diagnosis. They can be classified into suspected cases, which means any febrile illness accompanied by rash; probable, a case that meets the clinical case definition, has non-contributory or no serological or virological testing, and is not epidemiologically linked to a confirmed case. Confirmed case refers to a case that is laboratory confirmed or that needs the clinical case definition and is epidemiologically linked to a confirmed case. A laboratory confirmed case doesn't need to meet the clinical case definition. Just a positive laboratory test will confirm the case. Cumulative incidence refers to the number of new cases of disease in a population over a period of time divided by the population at risk at the beginning of the period. Note that only new cases are included in the numerator. Only people at risk are included in the denominator. To obtain incidence, you may need to follow up healthy people for the specified period of time. Cumulative incidence is a measure of risk. It indicates the probability of developing a disease in a person over a period of time. It is the best measure for studying the etiology of disease. The second measure is incidence density, or person-time incidence. It refers to the number of new cases in a population during a time period divided by the person time of observation. Person time, for example, a person year, is simply the number of persons multiplied by the number of years of observation. For example, 10 persons followed up for 2 years will contribute 20 person years for the denominator, same as 5 persons followed for 4 years. Incidence density represents the average rate of change in the health status of a population. It has no meaning at the individual level. Incidence density is suitable for diseases with extended period of risk, such as chronic diseases. It assumes that the risk is constant over the follow-up period. No difference between the early period of follow-up and the late period of follow-up, which is not always true. Has no meaning at the individual level. Can't be cumulated. Values can exceed 1. Example for calculating cumulative incidence and incidence density. 1,000 persons without diabetes were followed for 1 year. 50 persons of them developed diabetes. Calculate the cumulative incidence and incidence density. Cumulative incidence equals 50 divided by 1000, while incidence density equals 50 divided by 950 multiplied by 1, which is 1 year, plus 50 multiplied by half, since the 50 cases that developed the disease were not followed for the full year. Some of them developed the disease in the early period, others they developed it later, and the best estimate that they were under follow-up for half a year. So the incidence density is 50 divided by 975. That is 50 cases per 975 person years of follow-up, or simply 51 per 1,000 person years of follow-up. Now we come to prevalence. When we say point prevalence, we mean prevalence. It refers to the number of existing cases in a population at a point in time divided by the number of the population. Note that the number includes old and new cases, existing cases, at a point in time, not during a period of time. That point in time refers to the time of assessment of their condition. Cases with long duration of their disease are more likely to appear in the numerator than cases with short duration. That means cases are not representative of all cases. They tend to overestimate cases with longer duration of their disease. What is good about point prevalence is that it is very easy to have, much easier than having incidence or incidence density measures, because there is no need for a period of follow-up. It is just measuring at a point in time, not during a period of time. Point prevalence is not suitable for etiological studies, simply because, first, it overrepresents the cases with longer course of their disease. So, cases identified at a point in time are not representative of all cases of the disease. The second, differences in prevalence between subgroups of the population may merely reflect differences in survival rather than differences in incidence. If we have two groups of the population, one group well treated and the other group poorly treated, then we expect a better survival in the well-treated group, and this will lead to an increased prevalence in that group, although the incidence is similar in both groups. Third, distortion of temporal sequence. The cause should precede the effect, but in prevalence studies, we don't know which started first, the risk factor or the potential cause or the disease. We don't know which started first. There is no temporal sequence because both the cause and the disease are measured at a point in time. We don't know if the risk factor occurred before the disease or not. It may sometimes be a result of the disease, so the cause-effect relationship is distorted. So what is the main benefit of prevalence? It is very suitable for planning purposes. It is important for the policymakers to know how much is the load of the disease. They don't care whether the disease is new or old cases. They want to know how many medications for diabetes that they should prepare. They want to know how many hospital beds, how many physicians, how many nurses. All these are provided by the prevalence, not by the incidence. So, what is the relation between prevalence and incidence? This is shown in this equation. Prevalence equals incidence multiplied by duration. If the duration is short, less than 1 year, less than 1 unit, then incidence is larger than the prevalence. If the duration is prolonged, such as diabetes, hypertension, then the prevalence is higher than the incidence. Factors that affect the duration include death, cure, migration from the community. This is an example how to calculate prevalence. A survey was carried out in a population of 1,600 males and 400 females. 150 persons, 70 males and 80 females, were found to be hypertensive. Calculate the overall prevalence. 150 divided by 1,000. The prevalence by gender: males 70 divided by 600, and for females 80 divided by 400. Period prevalence refers to the number of existing cases in a population, that is point prevalence, plus the incidence during a period of time. It is a combined measure of point prevalence and incidence. It is often used to highlight the importance of certain diseases, particularly psychological diseases, and they are often used for advocacy. By now, we finished our talk about measures of disease occurrence, and we come to associations and to measures of association. What is an association? An association is an observed difference between study subgroups in rate of disease or mean level of any study variable. For example, differences in coronary artery disease incidence between males and females, or between the elderly and the young. Differences in mean cholesterol level in subjects with and without family history of coronary artery disease. A change in the value of a continuous variable with the change in the value of another continuous variable, and vice versa. For example, changes in systolic blood pressure and diastolic blood pressure. They are usually correlated, associated. We will discuss 4 measures of association: the relative risk or relative incidence, the odds ratio, the attributable risk, and the correlation coefficients. The first measure of association is the relative risk. The relative risk is the ratio of the incidence rate in the exposed group divided by the incidence rate in the unexposed group. By exposed, we mean people with the risk factor, and unexposed people without the risk factor. For example, smokers and non-smokers. Example, in a cohort study, 50 of the 300 smokers developed coronary artery disease over the period of follow-up compared to 25 of the 600 non-smokers. Calculate the relative risk of coronary artery disease for smoking. The answer is relative risk equal incidence of disease in the smokers, which is 50 cases over 300, divided by the incidence among the non-smokers, 25 of 600. This equals 4. The relative risk here is 4, which means that smokers are 4 times more likely to develop coronary disease than non-smokers. The next question: is the association statistically significant? Usually for this type of data, the chi-square test is the suitable test to assess the statistical significance, and I think it will be discussed to you by my colleagues. Now we come to the second measure of association, which is the odds ratio. In case control studies, we don't have data on incidence, so we cannot calculate the relative incidence or the relative risk, but instead we can estimate the relative risk through the odds ratio or relative odds. So what is the odds? If 60% of the cases are exposed, let us say for smoking, then 40% are not smokers. So the odds of smoking in the cases is 60 divided by 40. Same with controls. If 30% of the cases, of the non-cases or controls are smokers, then 70% of them are not smokers. So the odds of smoking in the controls is 30 divided by 70. Now we divide the odds of exposure of smoking in the cases by the odds of smoking in the controls to obtain the relative odds or the odds ratio. The odds ratio is an estimate of the relative risk, and it is a good estimate only if the disease is rare. That means if the disease is so common, the odds ratio will not be close to the relative risk. Only in rare, when the disease is rare, the odds ratio will be very close to the relative risk. This slide shows the famous 2x2 table, where the disease status on the top and the exposure status on the left. The cells are named as shown in the table, A, B, C, and D. Now, the odds of exposure in the cases is A divided by C, and the odds of exposure in the controls is B divided by D. So their ratio A divided by C divided by B divided by D, or simply AD divided by BC, which is the usual formula for the odds ratio. Returning back to our example, the odds ratio is AD divided by BC, which means 50 multiplied by 375 divided by 25 multiplied by 150, which equals 5. It is interpreted, the odds ratio is interpreted exactly like a relative risk. Smokers are 5 times more likely to develop coronary disease than non-smokers. Same as relative risk. And remember that the odds ratio is a good measure or good estimate of the relative risk when the disease is rare. The third measure is correlation, which measures how two continuous variables co-vary. The most widely used correlation coefficient is the Pearson's correlation coefficient, usually represented by small r. The values range from +1 to -1. +1 means perfect direct correlation. -1 means perfect inverse correlation. 0 means no correlation. A correlation coefficient below 0.4, irrespective of the sign, is considered weak correlation. It is important to remember that correlation doesn't mean causality, because none of the variables is dependent or independent. We don't claim that any of the variables is dependent or independent. So it has nothing to say about causality. The R, or the Pearson's correlation coefficient, measures the strength of the linear association between two continuous variables. If the association between the two variables is not linear, the Pearson's correlation coefficient is not a good measure. So what do we mean by a continuous variable? A continuous variable is theoretically a variable with infinite number of possible values. There are other correlation coefficients. As an example, the Spearman correlation coefficient, which is a non-parametric coefficient, and it is performed from ranked data, not the actual values of the data. This slide shows 4 scatter plots. All have a Pearson correlation coefficient of 0.816. In this slide, The first row shows Pearson correlation coefficients of 1, -1, and values in between. Note that the zero value when the scatter plot has no pattern. It is just like a cloud. In the middle, it shows also Pearson correlation coefficients of 1 and -1. The middle one in the center is undefined because it is horizontal. Now, in the bottom row, although there is a perfect relationship, the correlation coefficient is 0. The reason is that because the relationship is not linear between the variables. The last measure of association is the attributable risk, which refers to how much of the risk is due to a given exposure. We can have two types of attributable risks. The first is attributable risk for the exposed, and the second is the attributable risk for the population. The equation for the attributable risk for the exposed is incidence of disease in the exposed minus incidence of the disease in the unexposed. So, if the incidence of the disease in the exposed, for example, smoking, is 20 per 1,000, and the incidence of coronary artery disease in non-smokers is 5 per 1,000, then the attributable risk of coronary artery disease for smokers is 20 per 1,000 minus 5 per 1,000, in which equals 15 per 1,000. This means that smoking is responsible for 15 per 1,000 of coronary artery disease in smokers. In other words, if smokers quitted smoking, their risk of coronary artery disease declines by 15 per 1,000. The attributable risk for the population equals the incidence in the population minus the incidence in the unexposed. If the incidence of coronary artery disease in the population is 14 per 1,000 and the incidence of coronary artery disease in the non-diabetics is 5 per 1,000, then the population attributable risk is 14 per 1,000 minus 5 per 1,000, which equals 9 per 1,000. That means if diabetes is eliminated from the population, then the risk of coronary artery disease in the population would decrease by 9 per 1,000. It is clear by now that attributable risk is highly relevant to public health interventions, as it quantifies the risk reduction in the exposed people and also in the population at large if a risk factor is removed. On the other hand, relative risk and also odds ratio are relative measures and carries no information about the actual risk reduction for the exposed or the population. They are useful for etiological purposes. The number needed to treat, or simply NNT, refers to the number of people we need to treat to prevent one case of a given disease. If the incidence of coronary heart disease in treated diabetics is 5%, while the incidence of coronary heart disease in untreated diabetics is 12%, then the risk reduction attributable to treatment is 12% minus 5%, which equals 7%. So we have to treat 100 diabetics to prevent 7 cases of coronary heart disease. So to prevent 1 case of coronary heart disease, we have to treat 14.3 diabetic patients. That is 100 divided by 7. The number needed to treat is evidently important in cost effectiveness studies. Now, after we knew the different measures of association, we will discuss the criteria of a causal association. The first criterion is the strength of the association. The stronger the association, the more likely it is causal. Weak associations are more likely to be due to other reasons, such as confounding or bias, than strong associations. The second criterion for a causal association is consistency among subgroups of the study and consistency with other studies. The third criterion for a causal association is dose response, which means that the higher level of the risk factor is associated with higher risk of the disease. Another criterion of causality is temporal sequence, from cause to effect. That is, the cause is present before the disease. Specificity of the association refers to the situation where the risk factor causes only that disease, or that disease is only caused by that risk factor. Lastly, biological plausibility indicates that there is a reasonable explanation for the association based on available knowledge. However, the lack of an explanation doesn't rule out the causality of the association. When we identify an association between an exposure and disease, such an association should be scrutinized to know whether it is true or false. Before concluding that an association is true, we have to rule out sources of error that spuriously could have led to the association. First, we have to rule out the possibility of sampling error. This can be achieved by assessing the statistical significance of the association. If the p-value is less than or equal 5%, then sampling error is unlikely as an explanation of the observed association. The second source of error is bias, which is a systematic error at any stage of the study that leads to erroneous results. Another source of error is what we call confounding, بالعربي التشويش. The last source of error is interaction. All these concepts will be discussed a little further as we proceed. Statistical significance measures the likelihood of chance as an explanation of an observed association or difference. The p-value is the probability that an observed association is due to chance, when in fact there is no such association. A p-value of 0.05 or less is usually interpreted as statistically significant. Statistical significance has nothing to do with practical or clinical significance. There are commonly used statistical tests to assess the significance of associations or differences. The first and probably mostly used test is the chi-square test, which is commonly used to compare proportions or percentages. The t-test is used to compare the means of two continuous variables. It can be a pair t-test to compare the means of two dependent continuous variables, or it can be a two-sample independent t-test to compare the means of two independent continuous variables. The f-test, or analysis of variance, ANOVA, is used to compare the means of more than two continuous variables. These tests may be discussed with little more detail by my colleagues. Now we come to confounding. A confounding factor is a factor associated with both the disease of interest and the exposure under study, but it is not a consequence of the exposure. As an example, an observed association between smoking and peptic ulcer may be confounded by coffee drinking. If smokers drink more coffee than non-smokers, and coffee drinking is a risk factor of peptic ulcer. Bias is a systematic error in any stage of a study that leads to an erroneous findings. For example, we have observer bias, recall bias, misclassification bias, publication bias, and many other biases. For instance, cases may recall past events better than controls, and this is usually referred to as recall bias. Interaction is a synonym for synergism and antagonism. The joint effect of two factors on a given disease is more or less than expected based on their individual effects. This is the definition of interaction. For example, exposure to asbestos in smokers leads to much higher risk of lung carcinoma than could be explained by the separate effects of smoking and asbestos. If smoking alone increases the incidence of lung cancer by 2 per thousand, and asbestos increases the incidence of lung cancer by 4 per thousand, then exposure to smoking and asbestos together would be expected to increase the incidence of lung cancer by 6 per thousand. However, because of the interaction between smoking and asbestos, the increase in incidence would be much higher in smokers exposed to asbestos, let us say 20 per thousand as an example.